Hi, everyone. Welcome to the 2021 Colorado HIMA Virtual Annual Meeting. My name is Denise Wilson. I'm going to be presenting. There we go. Didn't want to move. Hi, everyone. Welcome to Colorado HIMA Virtual Annual Meeting. My name is Denise Wilson. I'm Senior Vice President at Denial Research Group and Appeal Masters. I'm also President of the Association for Healthcare Denial and Appeal Management, which we pronounce as ADAM. Today I'm going to talk about developing a meaningful denial and appeal dashboard. So if you are involved in doing appeals for denials that you're seeing at your organization, I'm going to give you some ideas and some tips on how to develop some dashboards that can help you manage and keep oversight of what's going on with your appeal work. So our learning objectives for today is to list that data that's relevant to denial and appeal management, to classify data in a meaningful way that helps bring information to light, and to build and implement dashboards that bring success to denial and appeal management. So let's talk about what is a dashboard. So a dashboard is a graphical summary of various pieces of important information. So it's information that's put into a graph form typically, so it makes it easy for you to have a good overview of your business. So there are common ways that we use dashboards in business, and one is strategically to monitor key performance indicators to make sure you're meeting your goals that you set out for your company. One way to use dashboards is in an analytical way to help discover trends or cause and effect of things that are going on in your business. And then a third way is to monitor and identify operational success and discrepancies. So today I'm going to focus on operational dashboards, how we can use dashboards to make sure that we're being successful in carrying out our work and to help identify if there are some places where we might be falling a little bit short of meeting our goals. So let's talk about classifying our data, because we have to put it in different buckets in order for it to make sense when we're talking about denials and appeals. And I think it will become a little bit clear as I go through this why it's important to think about the data that we're using in our dashboards separated into different components or different buckets. So the first thing I want you to think about is classifying your data by payer. So we think of government payers as being traditional Medicare, okay, fee-for-service Medicare, traditional Medicare, and Medicaid. And then commercial payers are pretty much everything else, all the other payers out there outside of traditional Medicare, traditional Medicaid. So our commercial payers would include managed Medicare, managed Medicaid payers as well, because those are actually managed, I guess is one way to say it, managed by commercial payers. So the reason why it might be important to classify your data by the different payers or payer groupings is because we know that payer operations are a little bit different when it comes to Medicare and Medicaid as compared to commercial. So for government, for example, for Medicare, when you're appealing Medicare denials, you have your 5 levels of appeal for traditional Medicare fee-for-service. Everyone in the country gets those 5 levels of appeal. If it's a managed Medicare plan, you get however many levels of appeal your contract might say, if you're contracted with that payer. So the appeal process is different and the outcomes can be different. You can have greater success, for example, appealing traditional Medicare than you might have with managed Medicare. So it makes sense to separate them out. You can separate them, of course, even further by saying, okay, we have government Medicare, we have government Medicaid, we have our commercial payers, we have our managed Medicare payers and managed Medicaid payers. But just for a high-level overview, I'm just going to suggest we classify our payers into two general buckets, one being government and one being commercial. The next thing I want you to think about is classifying your denials or your denial data and appeal data by issue. The issue is the reason that the case was audited by that payer or was denied by that payer. So why did that payer choose that particular case to audit, and why did they deny it? It could be for the same reason they audited it. So they did an audit for, let's say, the level of care for medical necessity, and they denied it for that. But let's say they did an audit for level of care for medical necessity, and they ended up denying because the procedure that was occurred during that inpatient stay, let's say, for example, they determined that that was not necessary, and so now it's been denied for the procedure. So the issue is going to be why the payer audited the case or why they denied it. So we'll talk about medical necessity, and we'll also talk about coding and clinical validation. So under medical necessity, there's some basic reasons for why a case gets audited or denied. Level of care means, was the care provided in the correct setting? Inpatient versus outpatient is what we think of most often. But it could also be, did the patient need to be in intensive care versus on a general floor? Some payers pay differently based on which area of the hospital that patient is, where the care was provided. So level of care is inpatient, outpatient mostly, or it could be ICU versus a general floor. Medical necessity of a procedure or service, and that's typically, we think of outpatient procedure and services because there's a lot of guidelines that are published by payers around what they will pay for when a patient comes into the hospital for hospital services and they receive a procedure or service. So meaning, did they have a surgery, a minor surgical procedure? Did they have services like physical therapy, occupational therapy? Did they have drug administered, IV drug administration? Okay, were those procedures or services medically necessary? Some of those could be done in inpatient setting and still be denied for medical necessity. So surgeries done on an inpatient setting, during an inpatient setting, or services provided, it could be medical necessity of that particular procedure. Maybe the inpatient setting is appropriate, but that procedure was not medically necessary for that patient, according to the payer. Readmissions, most payers we know Medicare, traditional Medicare looks at readmissions, most payers do too, look at unnecessary readmissions. Some payers pay a per diem, meaning they pay by day that the patient is there. So if they stayed longer than what's medically necessary, payers can deny the days at the end of a stay. Lack of authorization for services. So we see that all the time with commercial payers because they're the ones who say, well, you have to have your admission or your services authorized before we will pay for them. So there's a couple of different ways to think about lack of authorization for services. One is, did the hospital actually not request the pre-authorization? Did the patient not request pre-authorization for that service or for that admission? Or did the hospital request an authorization, but it was denied, stating that admission or that service was not medically necessary? So that can actually be broken out into two different thoughts there. Was it not obtained or was it denied? Now, typically, when we think about if the hospital didn't even obtain authorization for services, that's more of a root cause. I'm going to talk about root causes as well. That's a failing on the hospital side to not attempt the authorization. So that's not necessarily an issue because that's not, I mean, it could be an issue. You could say, okay, the payer denied it because we didn't even apply for authorization. We didn't even attempt to get authorization. That could be an issue, but it's also going to be, a root cause. And I'll talk about root causes in a little bit. And then experimental investigation, we see those denials as well on the medical necessity side. Okay, let's talk about coding. The primary issues that we see with coding is they may deny a wrong principal diagnosis. They may deny a secondary diagnosis on the claim, stating it didn't meet criteria to be a reportable diagnosis. They might deny a procedure, saying it wasn't coded correctly, or maybe that procedure wasn't documented in the medical records. Or DRG validation, which basically is anything that has to do with changing of the DRG. Maybe it's resequencing of the code or any other, maybe it is the, the discharge status, things like that, that have an impact on the DRG. And then clinical validation, the main things that we see for clinical validation are we may see straight clinical validation. They are denying one or more codes in the record because they weren't clinically supported by the documentation in the record. That's clinical validation. But we sometimes see where different diagnoses in the chart might be denied, one for not being clinically valid and another code for not meeting criteria to be a reportable code. So there could be a coding issue and a clinical validation issue, and we refer to those as dual issues, so coding and clinical validation. And then you can also think about technical, administrative, billing. Those don't fall under clinical validation. That's just another set of issues that could be things like duplicate charges, out of network. Some of those you may be able to appeal, some you may not be able to appeal. It could just be an error on the hospital side. But that's another bucket that denials can fall into. So the reason why it's important to separate these out is because, again, for one thing, you're going to have different people probably in your organization with different skill sets addressing these different issues. So it's important to separate them out that way. And then you're going to see different success rates for the different issues. Most hospitals will see different success rates, and I've got some examples of that coming up as well. So that's a good reason why you might want to separate out your data by issue. So we've done by payer, by issue, and now let's talk about by root cause. So the root cause is what failed internally at the hospital side, on the billing side, on the documentation side, on the claim side, that caused that claim to deny, okay? If you did everything correct and it still denied, then there is no root cause. But if you did something that really was incorrect, wrong, could have been better documented, didn't really support that, clinical code or whatever, then the root cause is what was that problem that you own up to that says, yep, this caused it to deny and it denied appropriately. Because that's going to give you information into where you need to focus your work on ensuring that you're educating your staff appropriately and, stopping those denials in their tracks. Let's stop them before they get in the door. Let's take what we learned from our root causes and turn that into our process improvement work and try to decrease the number of denials coming in the first place that are appropriately denied. Okay, so let's break those into root causes. So medical necessity root causes might be there wasn't documentation to support the level of care that was billed. There isn't documentation to support that the procedure or the service was medically necessary, and sometimes that can go back to a commercial payer's clinical policy bulletin, or for traditional Medicare, an LCD or an NCD, a local coverage determination or a national coverage determination that says, in order to pay for this particular procedure or service, we want to see this documentation in the medical record. We want to see that conservative measures were taken before you took this patient to surgery to fix whatever problem that patient was experiencing. The clinical documentation may not have been submitted timely, so that can go back to you didn't get authorization because you didn't submit your clinical documentation to the commercial payers for that inpatient admission. So that's your own internal root cause. We did not do this, therefore it was denied by the payer. So write your root causes out in a way that makes sense to you. And I would also recommend that you define them. Put a definition to what does it mean if I stamp this denial as clinical documentation not submitted timely, what exactly does that mean? So you make sure all the players on your team are using the same playbook. They're all using the same definition. Maybe there was missing or inadequate physician orders, and that's why it denied for medical necessity, because the physician order wasn't there. Okay, some other root causes. Let's talk about some coding root causes. Maybe a surgical procedure was coded incorrectly. Maybe a secondary diagnosis was not supported by the documentation in the record. Maybe the surgical procedure wasn't even documented in the record, or the diagnosis was not documented that it was placed on the claim. Clinical validation. The diagnosis was not supported by the clinical indicators that you would expect to see for that particular diagnosis. And so it was denied, and it was appropriately denied. Now, your root cause list, I wouldn't make it too long, because you want to be able to use it. You're going to be using it on a daily basis, and you don't want to make it so cumbersome that your appeal writers are not encouraged to identify those root causes. And it can, expand as needed. Sometimes you think you've come up with a really good list of root causes, and then you find something you didn't think about. And so you add that to the root cause, you educate your team, make sure everybody knows when that root cause is appropriate to assign to a particular case. Okay, so let's get into our dashboards now that we've talked about how to classify our data. So I'm going to talk about 4 different dashboards. One is going to be human resources, so that's going to tell us whether or not we have adequate and appropriate staffing to get our appeal work done, to manage the number of denials that are coming in the door. I'm going to talk about a financial management dashboard, and that's going to address our staff productivity. Are we doing our appeals efficiently? Okay, in an efficient manner, so we're not spending additional resources, time, money, cost to get our appeal work completed and filed. Let's talk about success rates, and that is the effectiveness of the work that we're doing. Are we getting the appeal outcomes that we expect or that we desire? Those are our success rates. So we've got efficiency and effectiveness. And then the root causes, which I just talked about. Your root causes help you understand denial prevention, help you work toward denial prevention. When you know what mistakes you're making in your documentation, in your billing, in your coding, then you can correct those mistakes and help prevent denials going forward. Okay, so let's start with our human resources, our staffing dashboard. So one of the things that you want to think about with your staffing is, what is the trend of denials that are coming in the door? Are your denials trending up? Are they trending down? Are they staying about the same? So in this one, we've got our monthly denials by month. That's our solid bars up and down. And then our dotted line is our trend line. And if we follow the dotted line from January through December, we can see that line is creeping up. Okay. So we know denials by month that our number of denials are increasing. Okay, so we want to think about when do we reach that tipping point when maybe we need to hire some more appeal writers in order to make sure that we have enough staff to address all the denials that are coming in, the denials that are appropriate for appeal. Okay, so I'm going to break it down in a little bit more detail. This is just a general overall trend chart dashboard to say, okay, this is our denials are creeping up, so let's make sure that we have enough staff to address that. And the other thing about the denial trend by month as well is to help you understand whether the root causes that you are addressing, whether that is helping with diminishing the number of denials coming in per month. So is that having an effect? Right here, you might say, well, we're putting a lot of effort into stopping denials coming in, but look, they're still increasing throughout the year. So what's going on? Are we not focused on the right places? Are we not really implementing good performance improvement to stop those denials, or are our insurers just auditing more and more every month? Okay, so just a good general overview of what the annual trends are. Okay, I think this gives you a little bit more insight into your annual trends by looking at your issues, because when you're going to talk about staffing, you're going to have different staff who address medical necessity, different staff who address coding, and different staff who address clinical validation. Now, you may have staff who have the credentials and the experience and the training to do all three of them, and that would be fantastic. We're all looking for those people who can address all three types of denials. But more often, you've got your coding staff who can help with clinical validation. You've got your clinical staff who can also help with clinical validation. And once in a while, you'll have a clinician coder who can do all three of them. So when we look at this particular one for our annual trends, the bottom one is kind of a tan goldish color. That's coding. And we can see, if we look at our trend line, which is the dotted line, our coding denials over the year are they're staying pretty steady. They've dropped a little bit as the year has gone on, but not a big drop. Clinical validation is that pinkish middle line there, and we can see that it's actually decreasing as the year goes on. It kind of had a spike there around April through June, but then towards the end of the year, the numbers have decreased. And then the top line is our medical necessity line, and we can see that one is creeping up. So when we're thinking about staffing going forward, we might be thinking about, if we're going to look for some more staff to help address our denials, we're going to look for our clinical folks who have that medical necessity, medical background. Okay, here's another way to look at, this would be a daily snapshot. Okay, so I've got snapshots and I have trends. This would be a daily snapshot to say, are we churning through or churning over as many appeals as we need to stay on top of the number of denials that are coming in. Okay, and that's going to depend really on how much staff you have and how many appeals per day that they can write. So that's a number you should have in your head, or in one of your dashboards to say, we know if we can do 60 coding appeals in a day, I'm thinking we're looking pretty good. If we can do 75 clinical validation appeals in a day, I think we're doing pretty well. If we can do 100 medical necessity appeals in a day, we're not doing very well if we look at these daily snapshots. So the left one is showing us the right appeal tasks that we have in our queues. This is how many appeal tasks are assigned, are ready to be assigned out to our appeal writers. So we have 35 clinical validation, 56 coding that need to be assigned out to a writer, 157 medical necessity that need to be assigned out to a writer. On the right-hand side, for today, let's say, we have 321 already assigned out to our appeal writers for medical necessity. We have 100 assigned out to our coders, 87 assigned out to our clinical validation folks. And I see I have a misspelling on validation. Sorry about that. So I would say we're in a little bit of trouble with our medical necessity staff, because if we say, well, we can do about 100 a day, well, already we've got 3 days worth assigned out, waiting to be completed, and we've got 150 waiting to be assigned out. And you know your denials are coming in every day. And so that would be a clue that, hey, we need to be giving that medical necessity team a little more help. However we can do it. Maybe we've got some clinical validation staff who can step in, who are trained in medical necessity, and kind of help get those numbers down a little bit. Okay, so that's a daily snapshot. Now let's talk about productivity and the number of cases that your staff can do versus the number of cases that are coming in the door. I'll try to go through this kind of slowly and make it clear to you. It's not difficult to calculate it, but it does take, putting some numbers together. So this is what I would recommend. Look at, when you're looking at your productivity numbers, look at a 3-month average, because as when we looked at those daily trends, you can see it can, we saw like a 3-month spike there in those clinical validation appeals a few slides ago. So I would average it out over 3 months, because you kind of want to ride out those highs and lows and not be like so reactive that you're constantly trying to bump up or decrease your staff. Because if you got too much staff, that's a problem too, because you've got to find work for them to do if you have more staff than what you need to get the denials done. So look at a 3-month average. Determine the number of appeals that can be written per month by a writer by issue. Okay, so if you know that your let's say your medical necessity appeal, that takes you, let's say, 2 hours to write, and you have 10 staff, okay, 10 staff, 2 hours per appeal, times how many hours they work per week, and then by month, you can figure out what that number is. Let's say your coding appeals, it takes about you expect those to be completed, let's say, in an hour and a half, or maybe an hour and 15 minutes, times how many staff members you have, times the number of hours they work per week, and then multiply that for a month. I just do times 4 for the month. I know some months are longer and some are shorter. I just do a times 4 to get my month. And clinical validation, same way. Now, once I figure out the number of appeals that could be written per month by your writer or by issue, I multiply that by 80%, because you want to account for time off. People don't work 100% of their hours, 40 hours a week times 4 weeks. They're going to have some time off, sick, vacation, etc. So I take that times 80%. So what I came out with for this example is, let's say our 3-month average for medical necessity appeals is 514 per month. So every month for the last 3 months, we have received 514 medical necessity denials that we wanted to appeal. 514 per month over the last 3 months. I know that my staff can write 468 medical necessity appeals per month. Okay, so 514 divided by 468, 514 coming in, 468 going out, makes my productivity for my medical necessity appeal writers 110%. Okay, so they're running the fastest on the treadmill right now. Okay, a few more appeals are coming in the door than what they can actually get written and push out the door. Okay, so they're running a little bit fast on the treadmill. Coding 102%, and my clinical validation staff 98%. So I'm pretty happy with that. I do want to keep an eye on my medical necessity team because they're working a little bit more they're getting a little bit more work in than what they can accomplish on a daily or monthly basis. Okay, so I hope that made sense. And you could do that, you can run that on a daily basis, do that as a daily snapshot. I do it at least every month just to see, am I at a place where I need to hire more staff, or am I at a place where my staff is not busy enough that I need to find some additional work for them to do. Okay, so let's talk about financial management and our staff productivity dashboard. Okay, so this is a daily snapshot that helps you understand how your staff are completing the work that's assigned to them. So this is the number of appeals that each of my appeal raters completed within the last 7 days. The first line on the left is how many were assigned to them. The second line in the middle, or column in the middle, it's how many they completed. And then out of the number they completed, the third column on the right is how many of those that they completed were late. Okay, so you may have, someone who's full-time that is getting 20 or 30 appeals assigned to them in a week, or somebody's working overtime and doing 30 in a week. You may have part-time or per diem staff who only get assigned 3 or 4 or 10 in a week, or maybe they're working on other projects. But what this allows you to do is see, compared to what was assigned to them, how many did they complete? And of those that they completed, were they late? So if you have someone who's chronically late on getting their appeals assigned, then you might want to say, for example, Brenda Jones was assigned 3. She got all 3 of hers completed last week in the last 7 days, but she did all of them late. Okay, so when we assign appeals out to our staff, we say, we have an expectation of when those appeals will be completed. Now, were they late for a reason that maybe Brenda was out sick for a couple of days? Were they late because she didn't have all the documentation that she needed to get them done? Something that you can look into and say, what's going on and what's causing this to occur. If someone, let's look at Archie Powell. Archie had 4 appeals assigned to him. He got 2 of them done. He got them done on time, but he doesn't have his other 2 completed yet. So what's going on with that? What's the holdup for not getting 2 of his 4 appeals assigned to him? So that's just a good daily snapshot to say, are we, moving through the appeals in a timely fashion? Here's another daily snapshot you might want to look at is, for those appeals that are signed out to your staff, how many are due in the next 2 days and how many are past due? So that can tell you if there's a bottleneck somewhere. Okay, so Tammy has 3 assigned to her that are due in the next 2 days. Is that an appropriate number for her to get done? Probably, yeah, 3 appeals in 2 days. So I'm not too concerned about that. But let's look at Georgia Meyer has 1 that's past due, and Andrew Miller has 1 that's past due. So what I recommend is, when you have appeals that are past due, if they're past due by a day or 2 days, that you contact those staff members and say, what's going on? Is there something we can help you with? Are you waiting for on some documentation that you don't have, or what's going on? Because when those appeals are sitting in their queue and they're past due, if they're waiting on additional documents, then sometimes they don't get additional appeals put into their queue that they could be working on while they're waiting for those past due cases to become complete enough for them to be able to work on those appeals. So this is a good management daily snapshot to say who's stuck and who do I need to reach out to see if they need some additional help. Okay, so let's talk about success rate, our appeals outcomes dashboards. Are you getting the overturns or the successes that you anticipate or that you expect? So this is one overturn rate, and this is an annual trend, and this is by issue. Now, I would recommend as well that you divide this out even further by payer, because I think you're going to see some differences between, as I said early on, between your government payers and your commercial payers. But let's just do by issue to start out. And our top line is going to be our medical necessity. Our top line is our coding. I know the colors are probably not real distinct. The second line is clinical validation. The last line is medical necessity. Okay, so if we look at our overturn rate by these three issues, and this is honestly can be fairly typical of overturn rates. Medical necessity are a lot of times the ones that we see the least success with. Coding, clinical validation, we usually see a little bit higher overturn rate. If we look at our trend lines between these three, they're all staying pretty even throughout the year. Okay, our top one, which is our coding, dropped a little bit. Not a lot. Clinical validation looks pretty like it stayed pretty steady. Medical necessity has stayed pretty steady. Okay, so that's a good annual trend to look at. And I would make these rolling. So not just January through December, but now we're into April, May. So look at the past 12 months. Okay, what's it look like for the past 12 months? Here's another way to look at it. You can look at your overturn rates by clinical validation, coding, and medical necessity, so you can see what your average is. This is for a 3-month snapshot. You can see 84% for clinical validation, 91% for coding, and 68% for medical necessity. Now, when you're looking at your overturn rates, I recommend that you look at cases that you took all the way as far as you can for appeal. So I always advocate for going all the way through the ALJ, for traditional Medicare, all the way to external review, if that's an option for a commercial payer to go outside the internal appeal process, and do your overturn rates that way. If you abandon an appeal halfway through the appeal process because now you've decided, well, this one isn't as strong as we thought it was, or something has come to light that says, you know what, we really did make a mistake on this. We probably shouldn't even appealed it at the first level of appeal. We're going to abandon this one and just accept the denial. I wouldn't count that as a loss. I would only count your losses as being the ones that you have taken all the way as far as you can, and you've still not been able to win it. And that's just my recommendation. Okay, so we've got our 84%, our 91%, and our 68%. So let's break it out by our staff and see how our staff's doing. So let's look at our clinical validation for our various staff members. And in this particular snapshot, this is a 3-month snapshot, I see each of our appeal writers and what their success rate has been. Anything that's below our average success rate, which was, let's go back to our slide, I think we said it was 84% for clinical validation. Anything below that is going to show up in red. So we can very easily see the 3 appeal writers who are below the average, and then everyone else who's above the average. Now, they're not too far below the average, so I'm not too concerned about that. And then also want to look at the number of appeals that they're writing, because you wouldn't want to penalize someone necessarily. I shouldn't say penalize, but be concerned about someone necessarily who has a low success rate, who's written a very small number of appeals, okay, because it wouldn't be, a good set to think about your average on. And vice versa, if they've written a ton of appeals, maybe their success rate is higher, but maybe that's based on the fact that they've written a large number of appeals. And so much of this, as I think most of us understand, so much of this, your appeal overturn rate can be based on payers and payer behaviors. So we might say, well, Lisa Bauer is less successful than some of her, let's say Jenny Pitts, who's getting 92% overturn rate. Lisa's getting 80% overturn rate. Well, maybe Lisa's writing the vast majority of her appeals for a particular payer who is just really, really, really difficult to get wins, whereas Jenny is writing a lot of appeals back to a payer who's a little bit more generous in their overturns. And so that's something to take into consideration as well. But that's just a good snapshot to see if there is someone who stands out to you as being not average according to their peers. Is there a reasonable explanation for that, or is that someone who maybe needs a little bit more education in the work that they're doing? Okay, so here's an example for our coding staff where the average was, I think 91% was the average for the team. And here we can see a big variability in the number of appeals that were written by the different staff members. So just want to emphasize that again, that is important to take into consideration as well. And then for our medical necessity staff, where we see our overturn rates being a little bit lower. And I see someone, Andrew Miller, who has written a good number of appeals, at 104 appeals, is only getting a 56% overturn rate. So that's certainly something I would want to look into, because that's pretty, significantly lower than his peer group. And again, could be the payer, could be the type of medical necessity denials that he's appealing. It could be a particular service line, cardiology. Maybe we're having some difficulty with physician documentation in that area. And so it's just a way to kind of narrow your focus down to where do we need to do some additional education or investigation into whether or not we're being successful. Okay, and our last dashboard we're going to talk about is our root cause dashboard, and that is for our denial prevention. Root causes, as I said, are going to be defined by the provider. You define your own root causes, and that is let's say the circumstances that you find that are behind appropriate denials and what you need to do at your organization to help correct that and help prevent those denials from occurring in the first place. So let's say for this example, this was a 12-month root cause snapshot, and we see the level of care not supported. We look at how many dollars were at risk, how many dollars were denied by payers because the level of care was not supported, and you agree the level of care was not supported because that's what you said the root cause was for that denial to be issued. Now, maybe you were able to get it overturned, maybe you weren't, but you feel that, in fact, yes, you could have done better in your organization to support that level of care in your documentation. Our second column is our procedure or service was not medically necessary. The third column might be that the clinical documentation was not submitted timely. Therefore, you did not get authorized by the payer, and that was the root cause for that appropriate denial by that payer. And then our last one might be missing or inadequate physician orders. And maybe that's just a small number of dollars at risk, and maybe you're not going to pull out a full-on campaign to start making sure you have your physician orders appropriate. Maybe your performance improvement is going to be focused more on getting that documentation to support the level of care corrected, because that is where you're leaking the most number of dollars. Okay, so let's look at, just narrow it down to level of care not supported, and let's look at our trend over the year. And this one actually shows that our trend, even though that was our highest root cause in dollars at risk, we can see where the dollars are trending down for level of care not being supported. So maybe we've already put a process in place to help correct the documentation to provide better support of that level of care in our medical records, and we're seeing the fruits of our labor, and we're seeing fewer and fewer denials come in for not supporting that level of care. Okay, and then let's look at, let me see, I'm sorry, I bumped. I just want to make sure I did not skip a slide here. Okay, let's look at our procedures or services not medically necessary. Now, this is a different story. That was our second largest number of denials coming in as far as dollars at risk. And when we break that down to see what's our trend then over the last 12 months, we see that that is going up. So maybe this is, if you've got processes in place to help correct the documentation for the medical necessity of the procedure service is not working, or you need to, or maybe you haven't put anything into place yet, but you need to consider doing that because the dollars are creeping up for this particular root cause. Okay, so that's another great dashboard that you can create. Okay, so to summarize what I've talked about today, some of the takeaways from this particular presentation is think about classifying your denial and appeal data in a meaningful way, and that is by payer, by issue, by root cause. And then also, you know, you can break it down by when you're looking at your staffing and your productivity and your efficiency and effectiveness, you can break it down by your staff as well to see if your staff is working efficiently and if they're being effective in the work that they're doing. So create dashboards that are simple and easy to understand. Some of the dashboards I presented today are dashboards you can use on a daily basis to make sure that you are getting through your appeal work timely, effectively. Appeals are getting assigned out as they should. They're getting completed timely. Others are trends to help you think down the road. Am I going to need to hire more staff this way, that way? Am I going to have to find additional work for my staff? Create dashboards that display trends as well as current status. I think I just said that. So what's my current status today? Do I need to be assigning more work out? What are my trends? What do I need to be thinking about for the future? Excuse me. Okay. If you have any questions or feedback about this particular presentation today, you can certainly email me at denise@ahdam.com. And I just want to thank the Colorado HIMA Association for inviting me to present, and I hope you found some meaningful and helpful information in the presentation today. So thanks, everyone. Have a great day.